Well, all right. Good evening, everyone. We're glad that you're joining us tonight. We do have folks that are watching online, so we're glad to have you all online as well. I know. So, tonight, what we have going, let me give you just an introduction, give you a little bit of some housekeeping. Am I on anymore, Jimmy? Come on now. What we got? Y'all hear me out there okay? Maybe I should start over. All right. Try it again. We will edit this out later, this part. All right, Jimmy, you good? What should I do now? You good now? I'm not going to be talking that much anyhow. So, all right, guys, welcome to church. We're glad that you're here. We're glad you're joining us online. What we're going to do tonight, man, it's my privilege to have these guys join me tonight to have this Q&A. A couple of things. Number one, we anticipate it going a little bit longer, starting 6:30. We know it could get late. Our children, preschool, and student ministries are planning on taking care of everybody until 8 o'clock. So at 8 o'clock, I'm going to tell you, y'all need to go get your kids, all right? But if we're not finished talking at that point, that's okay. We'll keep discussing, and as long as we have good discussion going on, we'll keep going. But at that point, I will ask you to go ahead and head out. I'll need somebody to let me know when it's 8 o'clock. How about that? Okay, then, secondly, you submitted questions for this. We received over 60 submissions from 60 different people. We had about 130 questions submitted. A lot of them were duplicate. A lot of them were similar or the same. And so what we did is we combined those and we grouped those. And your question that you submitted, we may not ask it specifically, but we're going to ask it ballpark on the topic that you asked about. Now, in the event that we don't get to your question or to the nuance of your question. So, for instance, one of the big questions we're going to discuss tonight is about fertility with the vaccine. That was asked multiple times, and there was some nuance in some of those questions. They weren't all the same. So in the event that yours wasn't answered exactly how you asked it, at the end, we're planning on giving opportunity for questions from the floor. Now, there is some decorum when you do that. We are showing this on live stream. We're videoing this. You cannot simply ask it out loud from your pew because we will not be able to hear it on the recording on TV. So you'll need to come to a microphone. I will give you the floor. We got microphone 1, 2, and 3. So you'll need to come to a microphone. I'll give you the floor, and we'll do that at the end. We won't have that kind of dialogue happening during the panel discussion. Now, some of the questions that came in, not a whole lot, but some of them were government related and governmental policy related. Some of them were church related and church policy related. Some of them were theological in nature. These guys are both Christians and they can answer theological questions, but we didn't bring them up here to do that. We're staying within the bounds of medical discussion. So the church policy questions, theological questions, we'll talk about those in a different setting. The governmental questions, I've not included those. Can discuss those in another setting, but this setting is going to stay within the medical field because that's what they're experts in. So I'm going to pray, and then we're going to get going, okay? Our Father in heaven, we thank you for Jesus above all else. Lord, we thank you for the blood shed on Calvary. We thank you for the grace and the mercy extended to each and every one of us. Father, we thank you for the blessings that you give us each and every day. Lord, we worship you tonight. Even as we're discussing these topics, Lord, I pray that it would be something that glorifies and honors you. Lord, I pray for these two men as they share with us tonight, as they share their heart and their expertise. I pray, God, you would bless them, give them clarity of thought, clarity of speech. And I pray, God, that you would just be honored in all that we do. It's in Jesus' name we pray. Amen. Well, all right, guys. I stood up there, but y'all just stay seated. You don't have to get up, all right? That's because I'm a preacher and I like moving around. But you don't have to do that. So let me introduce these guys, and then I'm going to give them a chance to share their heart, what's going on in their world, because we don't always see what's going on in their world. And then we'll get to the questions that you guys submitted. So next to me is Dr. Frank Cormier. Both these guys, by the way, are members of our church. When they're here, they're just Frank. You know, it's not Dr. Cormier, right? It's just Greg. It's not Dr. Riggs up here. So if I call them Frank and Greg, y'all don't hold that against me, fellas. I'm sorry. None of y'all call me Dr. Pritchard, so we you know, no big deal. But anyways, Dr. Cormier here, he works at Lourdes Hospital. He is in the ICU department. He's a doctor in the ICU. Dr. Riggs is a primary care physician here in Lafayette. Also is a director of one of the hospice. Is it Acadiana Hospice? Hospice of Acadiana. I got that backwards. So Dr. Riggs is kind of on the front end of dealing with patients and talking with them about these questions. Dr. Courmier is kind of on the back end in that ICU of seeing them on the back end of that spectrum. So we're going to start with Dr. Courmier. If you can just kind of share with us your heart, share with us where you guys are right now, what's going on in your world, and we just kind of want to hear from you.
All right. Well, first, I just want to say thank y'all. Thank you for letting me do this, to take this opportunity to get the information about that you need. Is so important for me to know that whatever decision that you make is that it's based on right information. You know, whatever decision that you make is yours. But what's important is, and what hurts me, is to know that you're making these decisions on information that's not correct. So after we leave here today, hopefully my big hope and my objective here is to make sure that you understand what's going on, that you understand that the information behind the vaccine and COVID itself and all those things, and walk out of here with a better understanding of what to do. And I think that it's also important to appreciate what's going on with us. I'm going to tell you a little bit. I'm going to give you an update here on what's happening on the Lourdes campus and specifically for our ICU. And I've already had some feedback that I'm using this as a scare tactic, and I'm not. Part of the reason is just so to give you information. The other thing is that I don't want you to be scared. We don't have a spirit of fear, but we should have a spirit of concern. I want you to be concerned for people around you. I want you to be concerned about yourself, your families. I want you to be concerned about me, my family, and your church family. I just want you to have some concern based on what's happening as we move forward. So I'm just going to read to you a little bit some of the facts. I kind of swiped them down this evening before I left the hospital. So more than 50% of our current hospital capacity is COVID. All right, so a little bit over 50% of our hospital inpatient stay is all related to COVID. Our current ICU capacity is 24 beds. We currently have 42 ICU patients. We are running ventilators in the emergency room. We have nowhere else to put them. We have a phased approach to a contingency plan I want to do on these events. And it's a 7-phase approach to how we respond to these kinds of situations. At the last surge, which was the biggest one that we ever had, we got to our peak. It took us about 2 months to get there. We've exceeded that peak on this surge in 2 weeks. Okay. We are currently blowing through our phase plan faster than I can imagine after only every few days. We're currently at phase, we're kind of making a joke at the hospital, we're at phase 5 3/4 because we refuse to believe we're at phase 6. But the reality is that we're probably at phase 6 at this point. We only have one more phase to go to. What that means is this. If we exceed phase 7, then what we're entering is to a situation that is never before done. We always have plans and these theories, and we talk about doing these things in medical school as part of, kind of an interesting escapade in the what ifs. But this is now our reality, where we start doing what we call crisis planning, or crisis standards of care. And that phrase you're probably going to start hearing in the next couple of weeks if we don't trend off this curve, where some people that are going to come to the hospital and we're going to have to decide who gets treatment and who doesn't. And that's hard. That's not a situation I want to be in. I don't want to have to make that decision. So that's why I need your help. And that's why we're here today. And I hope that you'll lend me your ear and hope that we can come together on this.
All right. Thank you, Dr. Courmier. Dr. Riggs, you're seeing patients each and every day and answering questions all the time. So what are you hearing? What are you seeing?
Well, we have all these questions here that we're going to go through. And, Frank and I are answering these questions every day, different settings, but same questions. And I think if we just set this up correctly, if you could understand, I think you're going to hear the heart of Frank and his brokenness as he tries to deal with loss and struggle. But the heart of both of us and most of my peers is similar in the sense that, we went into medicine to heal. We wanted to be healers. We wanted to be Christ-like healers. And sometimes that means diagnosing and treating patients, and sometimes it means, hand on a shoulder or a hug or praying with a patient. For us as Christians, the latter can be very powerful. And as we kind of try to digest the situation we find ourselves in, we're constantly looking at data, and we're trying to follow science. And really what we're trying to do is find truth. And Christians, I think, more so than most demographics, should really be able to understand that effort, the idea of searching for truth. It's a noble one. It's one that should be pursued. And as we apply it to this setting, we follow the science, which is really the search for truth. And we do that in a few different ways, and I think this is a little bit lost in some arenas. We try to find the most accurate information we can. Not all information is accurate. Everyone knows data can be manipulated, sources can be tainted, and so we really try to siphon out what we can trust from what we can't. Modern medicine, the last several decades of medicine, we use a term called evidence-based medicine. Evidence-based medicine implies that we're not just sort of shooting from the hip. We are looking at data. I've had a lot of people tell me, well, I trust you, I just don't trust the data you're receiving. And, and I kind of get that to some degree, but it's a little naive to think that we don't understand where the data is coming from, how to interpret it, how to tease out the stuff that's not reliable from the stuff that is. And, I use an analogy a lot in my office. If Frank over here told me that, eating 5 blueberry muffins a day was going to prevent COVID, he might be right. We'd have to test that theory, and so we'd maybe set up a design of a trial. We'd say we're going to put 100 patients here and 100 patients here, and these guys are going to eat their 5 blueberries, and these guys are not. We're going to see who gets more COVID and who doesn't, or who dies from COVID and who doesn't, and we're going to use that as empiric data. Now, if we apply that to an actual trial, it might be a pill, and we might say we're giving them placebo and them not, and that's what we call blinding. We're going to make sure they don't know what they're getting, and even the researchers don't know who's getting what. And that eliminates some bias. And then we're going to try to randomize it, meaning we're going to try to make sure that there's the same amount of 50 to 60-year-olds here as there is here, and 40 to 50-year-olds and 30 to 40-year-olds, and there's going to be the same number of males and females here as there are here. And there's going to be the same number of health characteristics here as there are here. And the more and more and more we do that, the more we rule out all these biases and variables, and we start to get closer and closer and closer and closer to truth. That concept creates what we call levels of evidence. And I'm spending some time here just because I want you, it's going to set the stage for how we answer our questions. And if you don't understand that, it's hard to kind of get on the same page. But as you kind of climb up what we consider escalating or more reliable levels of evidence, that's the type of thing we're doing. Now, if you have a bunch of those studies back to back and they're all saying the same thing and you analyze them together, we call that a meta-analysis, and that's the most accurate form of data that we have. So many of the questions we're going to answer, you can look all over the place, the internet, elsewhere, and you can find a lot of different answers to these questions that would seemingly contradict. Our job is to look through all that, through the stuff that's not accurate to the stuff that is, to the reliable. Now, that data doesn't just come to us, packaged from the CDC. It's independent data from academic institutions. It's international data. It comes from all over the place. So this is not just from one source. And it's even more reliable when it is from multiple sources and it's saying the same thing. So just understand that our hearts are to be truth seekers, and science is really the search for that truth. I think that, a lot of people view science and faith as two separate things. I don't think they're contradictory. I think they're complementary. And when we really, truly do that, I think God smiles. I think we're, much in the way maybe a father might delight in his son or be flattered if his son follows in his footsteps in his career or takes interest in a hobby that he has. I think God likes when we study his creation, and that's what we're doing here. This is what science is. We're studying his greatest creation, and in this case, his greatest creation is getting sick. And so we're trying to find ways in which we can utilize what he's created and what he's given us and our intellects to make people less sick and keep them from dying. So if you understand that premise, I think, and if you understand what our hearts are here, I think we'll have a more productive conversation.
So where's the line for the blueberry muffins? That's what I'm interested in. And I would say, do I?
You already ate them all.
All right, I'm just going to walk off now. So, and I would assume that with COVID, pretty much everybody in the world is working overtime trying to figure this thing out. So there's, I'm sure, a ton of research going on globally on this. So thank you guys for sorting through that and helping us with these answers. We're going to go ahead and get to the questions. Again, I want to remind you, you may have asked a question similar to one that I'm about to ask. We're trying to group them and summarize them a little bit. And so if I don't ask the question as nuanced as you asked it or as nuanced as you need it, write it down, jot it down, and come back and ask it from the floor later, okay? So we're going to start with some treatment questions, a lot of questions about tests, a lot of questions about treatment options. So I'm going to let you guys leg wrestle over who gets to answer what. So let's talk about tests. Can you kind of briefly give us the overview of the different types of tests? One of the questions was, are they accurate? Can we trust them? Is it capturing true COVID, or is it flu and all these other things that are just showing up as COVID? So who wants to run with that one?
Yeah, I'll take that one. So,
okay, go ahead.
So we have, throughout the pandemic so far, we've had three main types of tests. One we threw out we haven't thrown it out, but we haven't used, it's not a diagnostic test, that's your antibody test. Then we have two other main types of tests, that's our antigen tests and our molecular tests. Both are still used. Our gold standard is our molecular test. You might have heard of it as a PCR test. These tend to be the most sensitive, the most specific. Now, there is no confusion on PCR tests. They look for genetic material that's produced by the virus. And, flu and COVID, these are very, very different viruses, so there's no inaccuracy. In fact, many of them can test for 20 different viruses and pick out the one that you have, and we do that sometimes in the hospital. We have respiratory viral panels at the hospital, then we'll run them, we'll have 20 different PCR results, and it's an RSV or whatever. So it's very accurate. There is no misdiagnosis. It's just not something we see.
Good. So it'll differentiate between the two. So this, if you're looking at I say the two, it'll differentiate between like the flu and COVID. It can tell you one or the other. Go ahead.
Yeah. So it's a whole panel that we have that will actually screen you out for about 23, 24 different viruses. So it's not just one, but you get a whole panel usually in the hospital that will identify. This has to do with the way the PCR works, is it's identifying which genetic sequence is present that's only in that particular virus. That's why these are very, very accurate. Testing for a PCR is 99% sensitive, 99% specific. You really just can't get much better than that in medicine. You never get 100%. So it's about the best that we got. And so, you know, negative, the problem with these tests is usually comes in the false negatives. And so on occasion, you might get a negative, but with a doctor looking at the patient going, I have a really high index of suspicion, that's what the phrase that we typically use, we'll retest. And then and if 2 negative tests with a 99% capability, for sure you can't have it. Yeah.
What about the variants? Like when you're testing, does it tell you what variant that is? I mean, and you hear certain percentage of cases are Delta variant, right? So can they tell that with the test, or how do they discern that number?
Yeah, so that's not done at the local level typically. So you take your swab, a number of samples are sent to research laboratories that do genomic sequencing. Genomic sequencing can identify certain patterns of repetitions that are more consistent with one variant versus another. So when someone says, if you heard, you know, that there's 83% in this area is, you know, made up of Delta variant COVID, that means that if there were 1 million swabs, maybe they took 1,000 or however much, and of that 1,000, it was 83% Delta.
So is there a really good time frame for being tested after symptoms occur to help avoid a false negative or a false positive?
We test kind of, so yes and no. So we want to test as soon as you're able. But yes, the test is a little bit more accurate a couple days in the illness, and maybe day 3 to 5 would be a little bit more accurate than right away. False negatives are more common early than they are a couple days in.
All right, so let's start with treatment. All right, you test positive. Dr. Riggs can speak to the at-home treatment there. A lot of questions about what's normal, what can be done. So kind of share with us. I test positive, come see you. You tell me to do what?
Yeah, so this is tough, and this is probably one of the most logical questions that I face day in, day out, or anytime we have these conversations, because it makes sense. You have an illness. What's my treatment? I should have a treatment. That's a tough one because we don't have a great treatment, and that's not for lack of effort. There, as you mentioned, there's literally thousands and thousands of studies ongoing. One of the things that we find with viruses is that the virus itself doesn't always cause the majority of the issue, but rather your immune response to the virus. So with viruses, oftentimes they're in and out, you know, maybe a few days. If you're diagnosed, let's say you start having symptoms, you think it's a cough, cold, you're day 3, day 4, day 5 into symptoms before you actually get tested. The virus may have kind of done its damage at that point. If we come try to put you on an antiviral or some other agent that we've studied and we think might help, it's kind of too late at that point. So we don't have a lot of great treatments. If we try to specifically focus on the immune response, well, we can do that, and we have ways to do that. But oftentimes, the side effects are greater than the benefits. And, you know, we're going to talk about vaccine safety, and we're going to talk about other things. But there is no greater concern amongst physicians than the safety of the treatments that we offer. You know, we will not give someone something that is unsafe unless it is absolutely the only option to save their life. So we don't have a lot of treatment. We do a lot of supportive care. In high-risk patients, a lot of people ask about monoclonal antibody infusions. We do that. That is a reasonable option. It does seem to reduce hospitalization and death. So we do that. Both hospitals have that option, outpatient infusion centers. So most of our high-risk patients, that's where all the data is in high-risk patients. So we do that, and that seems to help.
Yeah, so the infusion, I think when people get it, they hear, all right, infusion's the way to go, right? What are the gating criteria for when you say, go get an infusion, and then like how long into your diagnosis do you typically do that?
You know, we try to, the criteria within 7 days, and with one or more risk factors, and that there's age and obesity and diabetes, heart disease, lung disease, all the things you might think typically will qualify you for that. It looks like it's probably beneficial, maybe even beyond that. But that's typically when we give it. We try to give it as early as possible. We want to mitigate disease as early as possible.
Okay, good. So, one of the questions that came through multiple times when you're talking about this at-home treatment, you're talking about the hydroxychloroquine, you're talking about the ivermectin. So those types of treatments, there are some who will swear by that. I see a lot of data out there. I say data, a lot of information out there on, man, that's the way to go. Can you share with us, either of you, kind of how does that fit into your treatment? Is there a specific situation you use that? Is it not used? What kind of help us with that?
We don't have, I don't know a single doctor who has anything against any of these medications. We both use them early on. Hospitalized patients, outpatients, we both use hydroxychloroquine early on. There was some observational data that suggested, hey, maybe this has some benefit. We talked about that early on, quality of evidence. As we, got more and more and more and more quality of evidence.
I did use it against my wishes, to be clear. I was threatened to use it.
His arm was twisted. But as you get more and more quality of evidence, you start to realize, okay, well, this trial shows it's not beneficial. Maybe it's harmful. This trial shows it's not. Again, this is international. There's a UK study. There was a WHO study, the Solidarity trial. There's a recovery trial. There's all sorts of trials. I mean, these are enrolling hundreds, if in some cases thousands of patients into these studies, randomized control trials. So there is no bias here. That's the whole point. All the studies saying the same thing. The weight of evidence is too profound to ignore that. So while it's probably not overly harmful, there is some harm. It just doesn't have any benefit. So it's almost like a false sense of hope. And ivermectin appears to be going the same way, although it may have even more harm. Frank can talk more about that.
There was recent evidence just last week that was published about ivermectin that it didn't improve hospital mortality. It didn't improve hospitalizations, or it didn't prevent you from being hospitalized. And there is a signal there for an increased risk of shorter time to ventilator need. So there's some evidence of harm with ivermectin in particular, and so that has really been quashed in terms of it as an option.
So, kind of speak to this. This wasn't one that people asked, but one that I'm asking, and it's not on my list here, so it's off the cuff. It may not come out right, but I'm pretty simple when it comes to this, and let's say I have a friend and a doctor gave him one of these medications, and within a couple of days, he's right as the rain, and that's pretty good evidence that it's all good. So I'm demanding that when I come, right? So kind of share with us kind of the viewpoint on that.
I'm glad you asked that. That is a wonderful question. So many people, and I get it. We look and we think, man, these doctors are saying that everybody gets COVID, dies of COVID. And, that is true if you see him. Don't see him if you have COVID. But in my world, I see all kinds of patients do fine with COVID. I see some patients say, man, that wasn't even as bad as the last time I had a cold. And that is, I tell people all the time that a good 15-20% of my patients, it's really, really mild, especially if they're really healthy. That does tend to be the case in some situations. Another good chunk of them, maybe another 30-40%, it's more significant. Maybe not to the point where we're talking hospitalization, but it's more significant. And then a large percentage, probably a third of them, it gets more severe where we are starting to think, are we going to head down that road towards hospitalization? So you can imagine, if that's the case without any treatment, if I'm telling you, okay, well, maybe 80%, 75, 80% of these people are going to have mild to moderate disease, and they take hydroxychloroquine and start feeling better, they go, it worked for me. And I hear that all the time. Well, my friend took this, and man, he felt right as rain, a couple days later. Well, you might have just taken a medicine that you would have been fine either way. I can tell you I hear that all the time on no medicine whatsoever. People getting through it, people feeling better. So that's what we call a little bit of anecdotal evidence, where somebody or who maybe did well on something, and so it leads you to believe that. The way we try to determine if that anecdotal evidence is correct is we run trials, and that's where the trials came in.
All right, good. Let's kind of move to a couple of prevention questions. We had the governor came out with the mandate this week and really emphasized masks. There was some pushback
on media on that because earlier this year we're told if you've been vaccinated you don't have to worry about masks anymore, and then now in the last few weeks the CDC camp comes out, the governor follows that here in Louisiana and says, all right, if you're vaccinated you still need to wear a mask indoors. So that understandably leads to a little bit of concern and distrust in wearing a mask. So let's talk about the preventive a little bit. How does the mask play in? Is it still valid? And maybe you can speak to why the change.
You can see how quick Greg gave me the hard one, right? All right. This is going to take a little bit of an explanation, okay? But it's so important that I want to spend a little bit of time on it so everybody understands what's going on here. And understand the science, not just me telling you my opinion. But I'm just going to lay out the facts, and then you can tell me if we should be wearing a mask or not. How's that? All right? I hope that that's fair. Okay, so there are a couple of different ways that you can look at this. One way is a historical narrative. What happened in history? What has happened before? This is epidemiological data where we look at population-based statistics over other previous pandemics and learn what happened from then. The big med school, like what everybody has to learn, is the 1918 Spanish flu, right? That's the one that everyone has to learn about. He learned about it, everybody has to learn about it. One of the things about that is that they mandated masks back then, 1918, all right? No different than what we're doing now. And no different from now. Back then, it caused a huge uproar, and everybody was protesting, and no different now than what was before, okay? But the interesting thing is that there wasn't a national mandate like there isn't now. It was by state, and even by city back then, okay? So some cities were doing it, some cities were wrong. If you look at major metropolitan cities back then, whatever Spanish flu, and when they had mask mandates, their mortality statistics are lower than those that did not have mask mandates, okay? That's observational data. It's not great, but it's a hint that there may be something there, okay? So what I'm telling you is that you shouldn't rely on that data, okay? I don't, and you shouldn't, but it's a hint. Something is there, okay? So then we move forward a little bit in time, and we have further pandemics that have come along the way. The most recent, previous to COVID, is the H1N1 flu pandemic of 2009, in which we wanted everyone to wear a mask then, but no one mandated it then, okay? And so, interestingly enough, what they did was that they took a population that was wearing masks, that had to wear masks, okay, the healthcare workers, and compared them to the rest of the community and figured out that the healthcare workers weren't getting it. So, observational data, not great, more hints though, okay? Something's there, something may be there for us. COVID kind of changed everything for us, and we really have some really good, much more robust evidence now than we ever have about mask use. So here's kind of what's happened. And here's how much you need to understand. So for every infective agent that exists, there also exists a study with regard to how contagious that virus is, okay? The contagiousness, quote unquote, I'm trying to use words here as effectively as I can, of any infective agent is defined by what's called the R naught, okay, the R value of an infective agent. To give you an idea what that means, we'll take the flu. The average R value for the flu, now it's a little bit different every year because you got a different virus every year, but take it upon average, the R value is about 1.7. What that means is that for every one person that gets infected, 1.7 people will catch it from that person. And then from those 1.7 people, you get another 1.7 that catches it from them. That's how you get community spread. Okay, following me? Okay. So now that when you get community spread, the way that you reduce community spread is that you implement measures and you do things at the public health level, not at the individual level, at the public health level, that reduce the R value of that agent to less than 1. If you can get the R value to less than 1, let's say if I get the flu R value to 0.8, what then that means is that for every one person that gets the flu, 0.8 people get it. You can see it's less than 1. You start reducing the community spread of that virus, and then you stop seeing it. Okay? So now the R value for COVID initially, and we're going to call the initial one the alpha variant. Okay, that was the first when COVID first came out. The R value was then calculated to be 4. So much more contagious than the flu. And then, so for every one person that got it, 4 people got it. Then they initiated mask mandates. Recalculate the R value. It went down to 2.2. Okay? So there's a clear evidence there from epidemiological data that what we did is we reduced community spread by wearing masks. It wasn't perfect, okay? Using words like prevent is not accurate, all right? It reduces your risk, okay? So, and it reduces community risk, not maybe your individual risk, okay? We have to understand the difference in the statistics. I'm not talking about you or you. I'm talking about the community as a population as a whole, okay? And there's a difference. And so I'm reducing that risk from infecting people from 4 people to 2 people. I'm slowing it down. Now the hospital can take on that burden. You kind of start seeing the issue there. So now instead of a massive influx of infected patients, I'm reducing that amount. It's not perfect. Okay, it's not perfect. It doesn't reduce it to less than 1. Okay, if you include social distancing in that, you reduce the R value a little bit further. Sometimes there's a little bit of a range. It's about 1.8 to 2. Okay. It's still not less than 1, but it's better. So then say, okay, now we have evidence that shows that if you combination mask and social distance, you will reduce community spread. Okay, so there's your evidence. And so now we fast forward. Now we have the Delta variant. All right, the R value calculated for the Delta variant is 8. All right, for every 1 person infected, 8 will catch it. To give you some context and understanding how contagious that means, for me as a physician, that for me is scary. The reason is because smallpox, which is eradicated now, the R value is 6. It's more contagious than smallpox. Okay? This is bad. All right? It's not as deadly as smallpox. I'm not saying that, but it is much more contagious. And so when it gets that much more contagious, it's true. The mortality is pretty low. Not very many people are going to come to the hospital. But when everybody gets infected at one time, you can see a certain proportion of those patients are going to progress to the point of needing the hospital, and we become overwhelmed. And that's the issue. And so if we implement mask use now, we don't know with the Delta variant, because it's new, that if you re-implement these issues, what the R value is going to fall to. I don't know. But the data inferred would tell me that it's going to help. Okay? Is it going to help sufficiently? We don't know. I'm not saying that it will or will not. I don't know. But we got to do something, because I just read you what's happening in my ICU today. We got to, so we have to do something. So I'm not suggesting in the slightest that if we just put on a mask and socially distance that this all goes away. Far from it. That's not the solution. But it's the solution today, so that instead of doing this in terms of hospitalizations, I kind of start to do this, right? That's what we want to do, so that I can start handling the influx of patients, so that I can deliver the care that I need to give, so that we're not overwhelmed in the healthcare system. That's the point, okay? So does that answer all that? Yeah, okay.
I think that was pretty good answer to that question.
Frank and I were on a panel earlier today, and I liked his answer better than mine, so I tossed that one too.
Yeah. So, I mean, there were a lot of questions about this, and you said it. I just want to articulate it clearly. Putting a mask on, it does not guarantee that you are not going to get COVID.
No, and no reasonable
right?
physician believes that. No health official believes that. We're not talking, again, when you hear this stuff, we're not talking about you specifically. We're talking about the community at large, okay? Well, they're not thinking about you and your risk of COVID. They're thinking about community risk and hospital influx. That's what we're talking about. And there's a difference. There's a difference.
So what about if we put 2 masks on? Would that?
I
Would
feel
3
like
do
he's setting
that?
us up here.
I'm sorry. All right. So in a minute, we're going to talk about vaccines. But while we're kind of in this treatment, assuming that someone is unable to get a vaccine, and there are people that are unable to do that, what would you suggest masks, distancing? What other things might they be able to do if they're unable to get that vaccine to kind of be preventative?
I mean, I think that yeah, your second best option is when you're in public is to mask and social distance and to isolate, especially if you become of a known contact. You need to isolate yourselves to make sure that you're not you don't become part of the problem of spreading it even further, even though you may not get that sick. And implement those things. But it is, just to be clear, as we get into the vaccines, it is a very poor second choice. And I would think that, now just for the record too, Greg and I have not sat down and said, okay, what are you going to answer for this one? And make sure we're on the same page. So if he says something different, then fine. But I think one of the main goals here is to appreciate that him and I are coming from two different places, reading this stuff independently and coming up with the same answers. So I just want to kind of make that, just to give more weight to what we're saying.
Yeah, so on the other side of the story is that, no, I'm kidding. Nobody wants to go back to masking, but one of the things that I see a lot is it seems like we're flip-flopping on this. And that's not necessarily the case. It's more of what he's talking about, where early on, with a less contagious variant,
I forgot about the vaccinated, yeah.
Yeah, we weren't really seeing, no one vaccinated was getting COVID. You inundate an area now, though, with a much more transmissible virus. And yeah, you're going to start to see some breakthrough cases. And now we have some data that suggests that, if you are vaccinated and you do get it, it's likely going to be mild, but you can still spread it. So now we're in a situation where it's not flip-flop. It shouldn't undermine, your credibility. You're responding to the data. You're responding to the science. And if you didn't, it would just be ignorant and stubborn.
Yeah. So we actually have data previous to Delta that shows that when people got vaccinated, and were infected, that their viral titers were lower than those that were unvaccinated. Okay, and we have that same evidence now for the Delta variant, that those viral titers now that have and this has just come out just a couple of weeks ago, is the same as the unvaccinated. So for the Delta changes your infectivity level as a vaccinated person compared to what it was before. So the reason for the change now and adding back to mask mandate is because this new variant makes you, even if you're vaccinated, just as contagious if you get it. So that's different from the previous variants. So again, just what he said, this shouldn't undermine what we're saying. What we're saying is that we're gathering the evidence, and as we gather the evidence, we make new choices. It may change again later, and that's okay. We're responding to the evidence.
So basically, it's not they were flip-flopping, just the game changed, and we were having to change with the game.
Yeah, and I think it should be reflected.
Adjustments.
Yeah, it should be reflected though that the Delta variant is very different than the previous ones that we've done before. This is not just a mild difference compared to the others, and we're learning that now, and we're appreciating that. Man, this mutation is very different and makes this much like going from an R value from 4 to 8, for example, is a major shift in the ability for this virus to get you infected.
So let's talk about the Delta difference for a moment. This was on the third page of my notes. We were just on the first page, but Dr. Courmier wanted me to do this one next, I guess. So let's talk about that. You mentioned earlier that the R0 was double the previous strains of COVID. When they say it's much more infectious, you talked about kind of the science on that. What does that mean practical day to day? Does that mean that it's not 6 feet anymore, now it's 8 feet? Does that mean that now I got to wipe down my groceries? What exactly does more infectious mean? That may.
Yeah.
That's.
So I think that you're talking to scientists and doctors, right? So some of those questions that you're asking, I don't have evidence for. So I'm just saying, I don't know. And I think that part of the issue that has been going on for a while is that a lot of doctors that are trying to answer these questions are too scared to say, I don't know. So, and so it breeds more distrust when we're saying stuff that's different than other people. And then even with our own physicians, communicating different things, it becomes very confusing for you guys. So I'm just going to tell you, I don't know. Now, I know with the delta, with the R value of 8, it means it's more contagious. I am if you can't, because the science tells me so. Anyway, I'm in favor of reinstituting masks. But it isn't because I want to wear it. God help me, I don't want to wear it. It's ridiculous. But it's just it's a nuisance for sure. But the data tells me that this is important. This is the path for me and my hospital to improve so that I can continue delivering health care for the people that need it. So that it's that simple. It's not because it's not any particular stance I'm taking other than what the data tells me. And in terms of whether or not you should be wiping down your groceries or all that stuff, I genuinely don't know. If it makes you feel safer if you do it, I'm okay. And if you think I'm okay with not doing it, I think I'm okay with that. I don't think I'm going to advise you on something of which hasn't been studied. And so, I think that's the most responsible thing to say, is I don't know those issues. I do know that it's more contagious. I think we need to go back and we need to make more precautions. And I think that some of these precautions that is being asked about, you make the decision. If you feel more comfortable that way, please do it. If it doesn't make a difference to you, okay, and then we'll go from there.
All right, good. So let's kind of turn our attention to the vaccine. I think this was all that's where most of the questions were on the vaccine. So let's just kind of give a kind of an introductory question here to whoever wants it. Can you describe, I think there's 3 major vaccines, your Pfizer, Mrna, Johnson & Johnson in America. I know there are other vaccines across the globe, but those are the ones that we're familiar with. So can you kind of describe to us those 3, compare, contrast a little bit? I've got some follow-ups if you don't hit something, but I'm gonna let you roll with that.
Yeah, so I like to premise vaccines, and this sounds a little odd, but this is the most natural way to prevent illness. And people look at me kind of odd, and they're like, well, that doesn't make any sense. But when you walk through life on a day-to-day basis, I don't know if it's 10 times, 20 times, 100 times a year you come in contact with some type of virus. It could be in the air or wherever. And sometimes maybe you're just a little fatigued and maybe your body's fighting off some type of virus, developing antibodies. Sometimes you get sick. And sometimes you may not feel it at all. You already had antibodies that fought it off. But you're going through this process of exposure, combat, battle, virus, antibody formation, next in line, and you're doing this over and over again. So, God created this incredible immune system, and we don't honestly know how to mimic it. We're not really trying with a vaccine. We're trying to harness that. So that's all we're doing. So when you take in COVID, you're going through that process, except you have the whole shebang. You got the whole virus. You go through the whole illness. The vaccine is just there to try to give you a little leg up. We're going to give you a little in your arm. You're going to form your antibodies. And in the simplest of ways, that's how vaccines work in general. This vaccine really is slightly different in the mechanism, but that conceptually, that's what we're doing. So we're basically doing what your body does all the time, except instead of inhaling it and getting sick from it, we're giving it to you in your arm and letting you develop immunity to it. So these particular vaccines, the 2 that we're mostly giving are the mRNA-based vaccines. So mRNA is sort of instructions, and we inject that. Your body, your ribosomes, these cellular machines make the spike protein, which covers the COVID virus, and it's how the COVID virus enters the cell. You make these proteins, your body sees it. That's all it makes, by the way, nothing else, just the protein. Your body sees it, you develop antibodies to it. Hopefully, when you see the real thing, you have antibodies to the entry protein of the actual virus, so it's not able to enter into your cells. Okay, so that's really all it does in the simplest of ways. And we can go into a lot more detail than that, and we can talk about it more, but that's kind of what it does. Now, all that takes place in the cytoplasm, which if you look at a cell, you have the outer layer, you have the jelly, and you have the nucleus. DNA, all that genetic material, that's in the nucleus. This does not enter the nucleus doesn't have the capability to do that. It doesn't touch your DNA, doesn't interact at all with it. There is no impact on that. And it's almost biologically implausible to even fathom that. It just doesn't make any sense. That all takes place in the cytoplasm. If anything, it's a miracle that it actually works because it's so fragile. It's hard. The hardest thing about mRNA-based vaccines, and the reason why you haven't seen them already, they've been studied for years and years and years in HIV and rabies and others. The reason you hadn't seen them is because you hadn't been able to make effective ones because the body destroys it too fast and you don't get an antibody response. So these particular ones, they coated them in a little lipid protein, a little lipid layer that kind of protects it. And it lasts in your body maybe a day or two. By about 48 hours, it's kind of gone. So that's not in your body for years and years. It's literally, the hardest thing is to keep it there. In fact, we were talking about this earlier, that's why you need a second dose, because to get that antibody response, you need to do it a couple times because it's not in your body long enough the first time to create that immune response. The other thing about these vaccines is we get a lot of questions about the ingredients. What are the ingredients in these? And this was, everybody who's in the vaccine world understands that that's one of the biggest concerns that all comers have is, what am I putting in my body? And so they tried to waylay that. They tried to hit that on the front end and say, okay, we're gonna recognize that, and we're gonna try to accommodate that. So there are no preservatives. There is no latex, there's no eggs for egg allergies, and there are no metals. There's no metals in this at all. There's no metals. So we get that a lot. People, say they can, stuff they can stick to them and, like a magnet. And it's just, it's funny, but it's not a real thing. So there is the mRNA as the only active ingredient. There's a lipid layer, there's a little bit of sugar, and there's a little bit of salt, essentially. And that helps stabilize it because you're having to freeze it. And so those things help keep its shape so that it can actually do what it's designed to do. So those are Pfizer, Moderna, both mRNA vaccines, that's 90% or more of what we're giving these days. And we can talk about the other ones, but we're not giving as much of those these days.
All right, so I know in the development, there's been discussion and development of vaccinations just in general, that DNA strain from some abortive material, an aborted child back, 30, 40 years ago, has been utilized to help develop that. I don't know if it's stem cells, I don't know the details on that. Were these vaccines developed using that aborted material or the DNA strain of that aborted material?
Okay, so the Pfizer and Moderna were initially in the initial phase 1 trials, okay, whenever we were starting to first produce them, to test them, to see if they would even work at all, was used or injected into a cell line in a petri dish that has been cloned from, and I don't remember the exact year, but it was in somewhere in the 1960s, right? From an aborted fetus from the 1960s. And once that trial was completed, those abortive cells in the cell line, these are clones from them. They're not actually from the aborted fetus itself. These are many generations later. And after that, in successive trials, that was no longer used. And so that's not used currently. It's not used in the manufacturing of the current vaccines that are being used today. The J&J is a little bit different. They did the same thing. Multiple generations later of clones from an abortive fetus to start their phase 1 trial just to see if it would work or not. And then after that, they continue even to this day. So part of the issue with vaccines is that you have to do quality checks every so often to make sure that the vaccine lots are actually doing what they're supposed to do. The Pfizer and Moderna are no longer using this methodology to do their quality checks, but J&J continues to use the clones from the previous aborted fetus in the 60s to do their quality checks. There's a little bit of a difference there. This was actually a major concern at Lourdes, which is a Catholic facility, which is staunch advocates of pro-life, right? And after a long discussion with a lot of people that I don't understand because I'm not Catholic. They arrived at the conclusion that this was morally justified to do something that was cloned several generations later and not the actual aborted fetus, that were not actively participating or promoting abortion by taking the vaccine because we're not using them anymore. And you're doing something previously that was a bad thing, that we all agree was a bad thing, but you've made it and turned it into something good. So something good came out of something bad. So for all those reasons, the Catholic diocese allowed the vaccination to move forward. They do say that we would prefer you to use Pfizer and Mrna because J&J continues to use that cell line for their quality checks, but they do also say that if J&J is the only option that you have, then that's okay to do it. Because it's because the benefit is so far, then they're okay using it.
So originally, I may have bad information here, but I think that the Mrna and the Pfizer originally had a higher efficiency rate than the J&J. So one of the questions that was asked a couple times, if I got the J&J, the Johnson & Johnson vaccine, should I now get the Pfizer or the Mrna?
Yeah, that's mostly coming up in this. I've seen it in Frank, but if you've heard other, but mostly what I've heard that is in the context of, as we talk about booster vaccination and can I get, I got J&J, can I get Pfizer now? Can I get something else? And the answer is, it looks to be yes. And in fact, mRNA-based vaccines look to be creating a bigger, larger immune response. You higher antibody titers afterwards anyway, so it's likely that'll be a good recommendation anyway. So it shouldn't matter your original, should boosters come in? I think that's a question you have later on, so we can.
Yeah, absolutely. So the booster shot, are we talking about an annual flu shot? Do we get an annual COVID shot here? What do y'all think?
All right, I love answering this question. And the reason why I love answering this question is because you can see the science play out, and we're not guessing. So the answer is right now, we don't know. And the reason why the answer is that is because in the original trial, whenever they got the original emergency use authorization for the vaccines, the trial has not ended, okay? Everyone needs to understand that trial is ongoing. It hasn't stopped. Those people that were enrolled in the original vaccine trial are still enrolled into a trial that is due to go for 26 months. That's the idea of this, that's their protocol, that they were going to go 26 months. Those people are getting monthly follow-ups, either by phone or by in person, by a physician. And this is all around the world. It's not just the U.S. And what happens is that part of that monthly follow-up is that they get their blood drawn. And they look at antibody titers. And they graph them. And this not just going to say, do you have antibodies or not, but they're actually quantifying how much antibodies are this person making. And they graph it. And then when they start to see in the population pool that the antibodies start to fall, then you'll hear the CDC come out and say, now you need a booster at this certain time. Right now, as it stands, with the data, those antibody titers are still high. This is why when Pfizer came out earlier, you may have heard a number of weeks ago now, it says you may need a third booster shot, right? And the CDC and the FDA both unanimously came out and said, whoa, wait, okay? I don't know the reason why. I don't know the reason why Pfizer came out and said that, but I do know why the CDC and the FDA came out and said, wait, it's because we still have data that shows people are making antibodies. No, hold back. Okay, so they're still watching this, and if the antibody titers ever fall after sometime within this 2-year period, you're going to hear that we need a booster shot. One more caveat to this: in Israel, just so that y'all know, Israel is the most vaccinated country in the world for COVID. Okay, they have the highest vaccination rate in the world. It's exceeding 75% now, I think, and it continues to climb because they have a massive vaccination program. And it's not compulsory, but it's kind of like if you don't do this, you're not going to be able to do anything publicly. So it's kind of quasi-compulsory. But they have come out, their health ministry came out and said that they have data that shows in patients age 60 and older that their antibodies are now starting to wane. We're giving them a third booster. The reason why that we haven't adopted that yet is they haven't published that data. So all the scientists over here are like, we need to see it and we need to peer review it before we understand it and before we recommend it. And so we're not recommending it at this time. Stay tuned. It may come out. We don't know. But we need to see the data before any of us say, okay, now this is the time. Okay?
Yeah, great.
Oh, one more thing about
Go ahead,
boosters. Just so that we can be complete and so that you understand that there's a lot behind this, okay? All right. We also know that in organ transplant recipients, all right, the vaccine isn't working as well. For this reason alone, we should think about our fellow man, okay, and consider vaccination to protect them since it's not responding as well. But having said that, they are now in Israel. They're giving them the third shot, and they're detecting antibodies. So after the first shot, for people with an organ transplant, you know, they have to take a lot of immunosuppressive medications, a lot of them. So their response to after the first dose was only 20%, much lower than the general population. After you take the second dose, they only had about 36% conversion. So there's a good 70% there that did not respond to the vaccine. They got a third dose, 49% seroconverted. Half, even after the third shot, did not respond to the vaccine. This is very concerning for all of us in the medical world. And to try to protect these people, we need everybody else's help. And so that's the problem.
Yeah, good. So I'm going to move on a little bit, but before I do, I don't know if this puts y'all in a bad position or not, but are y'all able to, this question came up a few times, are y'all able to recommend, like if you were choosing one of the vaccines, which one would you choose? Are you comfortable doing that? You can tell me no and we'll move on, but.
Oh, no. I think the mechanism of action is so similar. I don't, between Pfizer and Moderna, I personally have a pretty strong preference, I think most of us do, to the mRNA vaccines. Pfizer's probably been a little more upfront with their data. They came out a little before, so it's a little bit more transparent, and I think you can tell we like our data. When people release data and we can peer review it, we can independently review it. Again, that's our mouth. You know, you're trying to decide what you can trust and what you can't. For us to be able to trust something, we have to be able to see the raw data, and analyze it ourselves. And so Pfizer's probably been a little bit more transparent with that. So that's what we carry in my clinic is Pfizer.
Yes, I agreed. So technically speaking, by the data, Pfizer and Moderna are equal. So it doesn't really matter which one. We feel like J&J is not equal in terms of efficacy in getting the virus, but it is equal in keeping you out of the hospital, and that's why it's still recommended. But it carries with it a small, very, very minute, but increased risk of blood clot. And because of that, we're like, if it's the only one you got, okay, because the risk of blood clot with COVID is 10 times higher, which is why we came out and still recommend it anyway. But if you've got options, why take the risk at all? Pfizer and Moderna don't carry that risk. So, and of the two, like I said, the transparency with the Pfizer vaccine has been more easy to get a hold of the data, more understandable, much more studied than Moderna. So it's just easier to recommend Pfizer only because it's been more heavily studied.
All right, so in the development of the vaccine, from everything I've ever learned about vaccine development, and I am a doctor, but I'm not the type that can help anybody. All right, so I don't know exactly on this, but I feel like it's supposed to take a long time to develop a vaccine, and this one seems to have been relatively quickly. And then also there are some governing bodies over this. And I think it's kind of an emergency approval. We don't have the full approval that a vaccine might have. So can you guys speak to that topic?
Yeah, there are a lot of reasons, so in short, it was rushed to some degree. I mean, we're in a pandemic. We need something. People are dying, so it was quicker. There's no question. But how did we accomplish that? I say we. How did the researchers who developed this accomplish that? And it really wasn't any one individual entity. It was a collaboration between a lot of different governing authorities, a lot of different individual private companies, researchers, scientists, coming together, realizing that we're in a pandemic, we're in a crisis, and we have to figure this out. Now, one of the important things to realize is that this particular platform, this method, I think you're going to see a lot more mRNA-based vaccines in the future. It does lend itself more to customization to different viruses. So when you have, we always like to talk about how, mRNA based technology has been around since the 90s, but when you have a platform, a foundation in place, it's almost like plug and play. You just sort of take the DNA sequencing, which we have from COVID already, and you plug it in. You kind of good to go. You have your product. So you shave off years of R&D, research and development. You just kind of got it ready to go. But the other big thing is, there was a lot of liability taken off of the developers. So in the form of red tape removed, in the form of concurrent production of vaccine. The vaccine normally wouldn't be produced. No company in their right mind is going to waste money on product before they know it's going to be effective and before it's going to be approved. When the government said, you get going with it, let the tests on go. We're going to have a lot of wasted vaccine if this thing doesn't turn out well, if the data is not correct, if the efficacy is not good, if the safety is not there. So that concurrent production, manufacturing while the trials were ongoing was a big part of it. Another big part of it is two things, and this is just basic epidemiology. But if you have to spend years waiting for enough people to be exposed to whatever you're testing something against, it's going to extend your trials. And we didn't have that problem, unfortunately, with COVID. We had plenty of it to go around. So you had a lot of data quickly. It didn't take a long time. The other part of this, too, is, one of the big things that can take 2-3+ years is to recruit enough volunteers to participate in your study. Also not an issue. You had plenty of people ready to roll up their sleeve and get their shot. They believed in it. They wanted it. They're happy to do it. That may not be you, but it was them. And so just those things, you're talking years shaved off from a collaboration, from concurrent production, from having volunteers, from having plenty of disease floating around to be able to test it and to really get real-time data. It just was a nice confluence of events.
Yeah, I'll just add that this would never have happened with the exception of a couple of things that had to happen in order for it to work. And it's quite a marvel, and we really ought to be celebrating this moment, because it really, 400 researchers, 36 countries, and they all got together, figured this out. We'd never done that for anything. And then people started looking around and said, we had research facilities that had nothing to do, and they were like, we're going to divert our resources here and figure this out, like shift everything, And then the Trump administration threw a bucket of money into this and said, whatever you need, here it is. Here's the money. And so $400 million, I think, was just lump summed. Boom, there it is. Now do with whatever you need to do to figure this out. There it is. And so when a drug is made, it's usually, what he was talking about, is made usually in a linear fashion. You do this trial, get results, look at it, analyze it, get the next one, get the results. None of that was skipped, but it was all done concurrently. Boom. Instead of doing it in a linear fashion, it was all done right here. Okay? And then the next one, all done in bulk right here. So nothing was skipped as part of the process, but it was all put together around the world using most of our money to figure it out. And that's how it came by. So, it was done quickly, but no safety check was skipped. Nothing was that. And, just as an aside too, as a scientist, we have a responsibility to make sure it's safe, right? We don't want a disaster to happen upon our, at hand. So none of this stuff was skipped. And if anything, and I can go into detail if someone wants the specific, but in general, what I'll tell you is that it actually went a little bit longer than we normally do. For the phased trials that were done to determine efficacy and safety. Normally for a vaccine, they go 2 months. They went 3. We'll just do an extra month just to be sure that it's okay, that it's safe, because we understood the controversies and stuff surrounding it. So it's a marvel of science that we got it together. And I have to say that, one of the things that we were talking about in terms of intermingling your faith and science, one of my favorite quotes is from Johann Kepler back in the 1500s. He discovered all the rotational, how all the planets rotated. And he said this, he said, "I can find no greater way to worship the Creator than to study His creation and be in awe." And I love that quote, because I pour into this stuff all the time, and I can't help but just break in worship when I read this stuff. And when you read about the complexity of what happened and how we put all this together, and God gave us a mind to figure all this stuff out. I mean, if you just sit back for a moment and understand what's been accomplished, you just can't do anything but marvel about it. It's just incredible.
That's a good thought. So I think the FDA typically gives the final approval on vaccinations. I don't think the FDA has given final approval. Have they, or am I right? Do y'all know?
Okay, I can talk about
And
the
so
EUA.
the question, I guess, if they've not given final approval, what's holding them back from doing it?
Yeah. Bureaucracy. All right, here's what EUA is. So emergency use authorization, this was implemented a while back when it was decided that what we needed was an opportunity that if we ever had an emergency that we could get things out quicker than we currently do, because the FDA takes years to come to approval, okay? So what happened instead was that, okay, a group of doctors that worked for the FDA said, okay, if we ever get into an emergency situation, what we're going to do is that if it gets approved by our panel of physicians, which includes two panels, the FDA has their own panel of physicians, and then they have to be verified by an independent panel of physicians that do not work for FDA. And then once those two are verified, they say, okay, it's verified by a group of scientists and physicians, send it out, we'll worry about the bureaucracy later. So what you're doing by saying, I gotta wait for FDA approval is essentially saying you're waiting for the bureaucracy to happen when the science is already completed, okay? So for a physician, we're like, EUA, great, fine, let's use it, and then you're telling, I want to wait for FDA approval. What you're essentially telling, what you're functionally saying to a doctor is that, I want to wait for some bureaucrat to sign off on this. Okay, you're not trusting the science. You're trusting the administrator sitting in his office that's got to wait and get through all the legal stuff, and the lawyers have to review it, and the politicians and all that have to look at it and make final approval when physicians have already done this. So EUA is just let's get past the red tape, get it to the people that need it, and then we'll figure out the formal FDA approval later. And that's it.
Good. So there were a lot of questions about kind of some specific scenarios. One is someone has already had COVID and they've developed the antibodies naturally. So in that scenario, do they still need the vaccine? What does the vaccine provide for that person that the natural antibodies don't already provide?
Yeah, that's a great question. It's definitely one of the better questions we see in clinic. So it's also a difficult question to answer, so we don't entirely know, but there are definitely patients who have had COVID and yet have very minimal antibody response. And a lot of that is just from actual measurement of antibody titers, but a lot of it is even from more powerful data, which is clinical outcome data. So someone has had it and yet they get it again. So that's going to always supersede some surrogate measure like an antibody level, the actual fact that they got it again. That's a clinical outcome. So you start to see that in patients with natural immunity. Now, it's thought that people who have milder cases are probably the bulk of these people, and then people who have maybe are older or immunosuppressed or maybe didn't have, just the same way they maybe wouldn't have responded aggressively to a vaccine, may not have responded aggressively to the actual disease process. So it has been shown that people who have had COVID and get the vaccine have a fantastic antibody response, superseding even that of just individual vaccines without a history of COVID. So I totally understand the reticence, but the other thing you have to realize is that antibody formation is likely at this juncture against a different strain than what we're seeing now. And so that also probably likely, just as we're seeing a slight decrease in efficacy of vaccine prevention, you're seeing those breakthrough cases, mild disease, but still some breakthrough cases. You're seeing a lot of breakthrough cases in patients who have had COVID before. So I have, just in actual clinical practice, tons and tons and tons of patients who have had COVID more than once. And it's not always a given that you're going to have it milder the second time, unfortunately.
Yeah, and so I was about to ask that question of if you had COVID with a different variant, how well might you be protected against the Delta variant? And you just said it's weaker against a different variant, right? Is that what I heard you say?
And I don't know if you've seen a lot in the hospital. So I haven't had a lot of I've had a lot of patients with COVID, this newer Delta strain, but I think we're literally in real time. We've had this for a couple months now. So we're literally kind of watching to see, and we don't really know. I think one of the maybe another way to look at this is, what I find is that most people underestimate the severity and danger of COVID, and they drastically overestimate the risk of the vaccine. So when you look across America, you're going to find, and this was an AMA did a survey across all physicians and found that literally about 98% of physicians are vaccinated. And the reason is because, gosh, we talk about that natural process. It's something you do every day. That's how most physicians view this. As long as the safety data and the trials is up to par, then this is a no-brainer. Just get a vaccine. We get vaccines all the time. Most people have had childhood vaccinations. Many of us in the healthcare world have flu vaccination all the time. We have never been able to show any major side effects to vaccines with any frequency, and so this is kind of a no-brainer. So most people look at this and say, okay, well, vaccine risk low, COVID risk high. Well, easy. Maybe I had COVID, but this is so low risk, and this will protect me. So that's why it's very easy for that recommendation to occur, although I do understand why some people might have a little bit of hesitancy. But the vaccine is really one of the few ways to guarantee that you'll have I shouldn't say guarantee, but to drastically reduce your risk of having severe disease.
All right, so let's say I've had COVID. I'd like to get the vaccine. Are there any side effects to taking the vaccine if you've already had COVID? And how long, do I need to wait a certain amount of time before I get the vaccine after I've had it?
Okay, so I'll do the waiting part first. So if you do meet criteria and you get the antibody infusion, you're gonna have to wait 90 days. And the reason for that is because if you get an antibody infusion and then you get the vaccine early, then you still have circulating antibodies that we've infused into you to attach to those foreign proteins that you're making from the vaccine and kill it before your immune system has a chance to respond to it. That's the theory. Okay? We don't have evidence to support that. We have a really sound theory without facts. So we're saying, okay, just to be safe, due to the and we calculate out the half-life of these antibodies, and we say you need to wait 90 days before you get a vaccine, just in case. We want to make sure that when you get the vaccine that it's going to work. So we're just to play it safe, if you get the antibody infusion, you need to wait 90 days. If you don't qualify or you don't get the antibody infusion and you get infected, you need to wait out the 10-day quarantine, okay, so that you're 10 days at home. And then when that ends, assuming that you've been without a fever for 3 days, then you can go get the vaccine at that point, okay? Adverse reactions? Okay, so...
adverse reactions in the context of I've already had COVID.
So just in full disclosure, I can speak from personal experience and from the data, okay? I had COVID February of 2020. No, April 2020. April 2020, that's what happens when you get COVID. Anyway, April 2020, and I recovered, and I got the vaccine as like the day one that it came out. And my symptoms were a little bit worse than I think than the average person. Not terrible, but 40% of people that get the shot will have some kind of minor adverse reaction. We're talking about body aches, fever, fatigue. You kind of feel like you have COVID for a little bit, for about a day, and then it goes away. There's a small fraction of people that will extend that to 48 hours, 36 to 48 hours, and small, and will go away, okay? So those are the minor stuff, and quite frankly, we, as physicians, that's great. Your immune system is doing something. So that's what it represents, and that's great, that's what we want. Doesn't mean that it's not working if you don't get those symptoms, because 60% won't, but they'll still be protected. Now, let's get to what we really want to know, right? The serious stuff. Like what can happen to me? Like bad if something happens, right?
You're talking just in general,
yes.
Not in the context of having COVID before. Like you get the
right.
shot.
You get the shot. What's my risk?
That's
right?
my next question. So you're good to answer that now.
What's my risk? All right. I want to preface by making I'm going to make this statement, okay? Because it's true and it's valid, and at least I think. Tell me if I'm right or wrong. Based on the evidence of the safety profile of the vaccine, this vaccine is more safe to take than Tylenol, okay? We have a mortality rate for Tylenol, okay? We don't have one for the vaccine. So this is much, much safer. Now, yes, there are risks. okay? There are risks, okay? I'm not saying that they're not, all right? But we need to appreciate that the risk is minuscule. It can happen. So for the J&J specifically, we talked about the blood clots, right? So the blood clot issue for J&J can happen 1 out of every 750,000 injections, okay? I like to compare that to what a lot of people at least want, birth control. So about 1 out of every 50,000 for a blood clot for that. So it's much, much less risk. The risk for COVID with blood clot, about 10 to 15 times higher. Okay, the Pfizer and Mrna don't have that serious reaction as of yet. After about 110 million doses now, we still haven't had that issue. Don't know if it'll ever pop up, but it'll be greater than 1 out of every 110 million. How's that? So what are the other issues? Anaphylaxis. So some people have an anaphylactic reaction to Pfizer and Mrna. That risk seems to be a little bit higher in patients that had previous anaphylactic reactions in the past. Okay, the average risk, okay, the pooled risk is 1 out of every 2 million. It's very, very low. Okay, but it exists. That's why for every vaccine that you take, if you go and get your vaccine, they're going to make you sit and wait 15 minutes just to make sure nothing happens. Okay, there's an EpiPen on standby just in case. Have never needed it. Why? Because it's 1 out of every 2 million. So it's going to be hard to find one, right? But it does happen. For those that are at risk, meaning that if you've had a previous anaphylactic reaction in the past, we are recommending that you stay an extra 15 minutes. So we recommend 30-minute stay for those. Some people have done that, still haven't had a problem, but it can happen. I'm not saying it can't, I'm just saying it's really rare, okay? Am I missing? I can't think of any other adverse. Oh, myocarditis, I forgot, yes. I knew I was missing something. Okay, so in ages 12 to 26, okay, there's an increased risk of myocarditis. This is inflammation of the heart. And in older people aged above 75, I believe there's an increased risk of pericarditis. That's inflammation from the sac that goes around the heart, okay? 96% of, let me back up. The risk of myocarditis is somewhere between 1 out of every 50,000 and 1 out of every 100,000, depending upon which study you're looking at. Israel, who has a higher vaccination rate than we do, has a little bit of increased incidence, okay, by 1 out of every 50,000. We are at every 100,000, so it's probably somewhere in the middle. Or it could be 1 in every 50,000 if you vaccinate everyone. But the point is that it's low, but it's probably one of the higher risks of the problems. What does that mean? What does myocarditis mean? What is that? And so that's, we're talking about inflammation around the heart, and is it serious? Well, first of all, COVID will give you about a 20-fold increased risk of myocarditis than the vaccine. Okay, so in fact, a lot of people who get COVID get myocarditis. And for this particular thing, we usually, it's usually outright, it's treated outpatient with ibuprofen. And it usually goes away by day 3. Okay, some people have extended all the way to day 7, but nobody really after that. There are no long-term effects of myocarditis. This happens with a lot of viruses. A lot of viruses cause myocarditis. It's usually just sent home on it. The reason why we know that we even got that myocarditis occurs is that originally children that were getting the vaccine were complaining of chest pain, so they got admitted. And they got all this massive workup done and figured out through, I think it was a positron emission scanning, that they figured out that it had, which is not normally done, because they're enrolled in a clinical trial, got to figure out what is this chest pain, right? So figured out, and it's just myocarditis. And after we figured out what it was, they stopped admitting all of them. Oh, it's just myocarditis. So up front, there was some admissions for it, but after that, none since. So we have the total overall rate, though, for hospitalization is just 4%. But all of those were at the beginning, we didn't know what the chest pain was being caused by. Now that we know that it was, they're not being admitted any further. They're being treated with ibuprofen and sent home. And usually it resolves on its own. In our physician's mind, it's not a serious risk, but it is one you should be aware of.
All right, so it's like right at 8 o'clock. We're going to keep going because we've got, a couple of the larger questions are the impact on fertility, the impact with autoimmune folks, and then some youth vaccination questions. If you have children in our children's or youth ministry or whatever, maybe if you got a spouse here, send them to go get it, go get the child or the children. They can come back in here if you want to, or I think we're on the TVs out in the hallway. They can watch it out there as well. So this is the time, all right? Time flies when you're having fun, all right, gentlemen? So let's ask about, there are a lot of, this probably was the most asked question of all of them, and that were questions about the impact on fertility, the impact on pregnancy. If they're pregnant, can they take it? What will that do to the mother? What will that do to the child in utero? What will that do to the child once he's born? So those types of questions. So can y'all address kind of that fertility question?
Yeah, and very valid concern. So the fertility one was a little bit puzzling, I think, to everyone in the medical community, because it kind of came out of left field. We never really anticipated that one. So it all boils down to there is a protein in the placenta, on the uterus, and there's this thought process that there's a slight similarity to that protein, and that of what the vaccine is utilizing. So the thought would be the antibody would attack that and result in infertility. It's not very plausible, but it was a theory that spread through social media and other things, and it really went viral. Probably the best way. So it's turned out to not be true. So as far as we know, all the data suggests that we're seeing as many pregnancies in vaccinated as unvaccinated individuals. There does not seem to be any sort of difference there, and for the most part, it clearly seems to be a fallacy. So you have American Society of Reproductive Endocrinology, who came out and made statements on that and reviewed data on that, and so we feel pretty confident on that. But you have more to say on that, because you.
I can, but I think and if you have more questions about it specifically with this,
I don't want to undersell that one.
I think some of the things is all right. It's just gonna. Is it
probably the best
difficult
way
to
I mean, I can
get
go down
pregnant?
to the cellular level. I mean,
Is it difficult
to go,
to maintain that pregnancy without having to terminate early? I mean, what?
Yeah, no. So
any of those concerns?
Probably the best analogy that I've heard, if people have sort of combated this misinformation is the idea that the immune system, or you, would walk down and you'd see a elephant and an alley cat and not be sure which one was which, because they're both the same color, gray. The immune system is not, it's able to tell the difference. In other words, it's not, these are not similar things. So, but the reality is, as we always do, you go back to the data, that doesn't make a lot of biological sense. The theory behind that doesn't make a lot of sense, but what does the data tell us? And we're just not seeing a difference.
Yeah, I meant to say miscarriage, not terminate early. That was, I'm sorry, that came out wrong. So if someone is pregnant, what's the time frame? What's the best time to get that vaccine?
Yeah, so there are two sources of data for this, one in the U.S. and one in Israel. I personally actually like the Israel one better. The U.S. one is more of an observational study of just looking at, okay, everybody, so some of the, and particularly healthcare workers in particular, it was, if you wanted to get vaccinated and you were pregnant, go ahead and do it, but we don't know if it's safe or not. And some people went ahead and did it anyway. And so for those that went it, they kind of called them up and said, hey, you mind enrolling into a trial now that you've already gotten it, and then we'll see. And so that's kind of how that went down. So about 100,000 people in that observational study, long term, and nothing happened. No adverse events to the fetus, to the child, and no problems with birth, and so on and so forth. And that's observational, so that we are always very, a little bit more careful about observational data. We look at that and go, okay, we feel a little bit better, but not sure. But the Israel data is really kind of puts the nail in the coffin on this. So 15,000 women pregnant, either in the second or third trimester of pregnancy, and they were vaccinated during their second or third trimester. Okay, so I cannot tell you if it's safe in the first trimester. I don't know. All right, but in the second and third trimester, vaccinated, 0 adverse events. Okay, now just keep in mind that our adverse event rate, the serious ones like myocarditis and blood clots, that sort of things are in the order of millions, right? So they only tested 15,000, so they didn't pick up anybody that got any of those problems. Okay, so but the point is that nothing happened in their pregnancy either. Babies are all fine, all delivered, no problem, all 15,000 of them. And including to that, then they followed those patients out a little bit further and say, okay, now you're going to breastfeed those patients, your patients, your kids, and then we're going to test that as well and make sure that that's okay. Antibodies are found in breast milk, and it seems, observational now, not sure, but seems to be protective to the infant at that time as well. So it seems like a really good idea to vaccinate in pregnancy.
The other contrast to that, just to interject, is that most of our experts in this is not our field. So most of what I have read from experts in this field suggest a much greater concern for COVID in pregnancy, which has clearly been shown to be more dangerous in pregnant women than in non-pregnant.
Yeah, so COVID in pregnancy has been shown to worsen outcomes in terms of preterm labor. So if you're pregnant and get COVID, you're more likely to go into labor early. And I have been eyewitness to that. So I've seen that.
All right, now, again, there was a lot of nuance in those questions, so we'll have a chance to ask, and the guys may stay up here a little bit if you've got a specific question on that. I'm offering y'all services. You're welcome. So another large area of questions was with people who are autoimmune, have immune deficiency, getting the shot, and I think you probably would say you do need to talk to your personal physician on the specific situation, but in general, can you speak to that?
There was some concern up front, and so there was some ambiguity in the recommendation specifically for patients who have rheumatological illness, okay, like lupus, rheumatoid arthritis, those kinds of psoriatic arthritis, those kind of patients. And so there was some ambiguity about that. We weren't sure for quite some time now, but recently I saw, because this came up with some other people that were asking me questions, so I recently found back in May 2021 was published by the American College of Rheumatology. And they, in this article, basically outlined all the data, and they basically, now this is going back and doing what's called a retrospective review. So everybody's already gotten, your 100 at that time, 100 million people have been vaccinated now, so they just kind of go back, take those pooled sample and go back and take a look again. Okay, now how many of those had rheumatological disease? So it wasn't a planned study where they were specifically looking at that population, but they went back and said, okay, some of those people that got vaccinated did have rheumatological disease, and let's pull those out and look and see what happened, okay? So that's what they did. So it's a retrospective review of rheumatoid, and everybody did fine. No problems. The risk for that population is the same for the general population. So they came out and made a statement saying that due to moderate evidence, so we have mild, moderate, and strong evidence. This is moderate evidence because it's a retrospective review, not a prospective randomized controlled trial. Okay, so we said, and I know these are big words, but just take my word for it. It's not as good, but it's pretty good. It's better than observational. That we pulled it out and said, we have moderate evidence to say that you should get the vaccine, and the risk of COVID far outweigh the risk of the vaccine. So they're making a recommendation to proceed with vaccination with some caveats in this particular population group, which is absolutely correct. You need to talk to your rheumatologist in particular to understand when the timing of taking the vaccine is correct. Because there are some caveats with rheumatological illnesses when patients taking certain medications that are suppressing their immune system. And there are some medications that need to be stopped and stopped at a particular time so that you can take the vaccine and have it work and then resume those medications at a particular time. And all of that is spelled out in this article of each medication. Each one's different. And then they also say that if you're having an active rheumatological flare, if your rheumatoid disease, whatever it is, isn't controlled, you should not take the vaccine at that time. Because you don't want to remove those medications that are trying to get control of your rheumatoid disease in order to get the vaccine, only to have a rheumatoid flare that may also be detrimental to your health. So you don't want to do it, you got to time it right and do it at the right time.
All right, very good. So we're still in the area of kind of concerns with the vaccine, so I'm stepping out of that autoimmune discussion. Is there any validity to the idea that it's the vaccines that are causing the variants to develop at a quicker rate?
Yeah, so this one, no, in short. So, but this is there is some logic to it, and you can follow it if you understand the biology behind it. You can follow where this is coming from. It just doesn't really pan out in real life. And one is simply because every variant we've seen has occurred in unvaccinated areas. So that's probably really our main issue here. So Delta, is derived from in India, so prior to vaccines. So it doesn't make a lot of sense, but it comes mainly from something we see in antibiotic use. So when we're treating bacteria, not viruses, but bacteria, overuse of antibiotics, incomplete eradication of infection can sometimes lead to these mutations, and you then over time develop resistance. And so that's why you may have, had a hard time getting an antibiotic from your pediatrician when your kid was sick, whereas 20 years ago it was, doled out like candy. It's because we understand that antibiotics breed resistance. We just don't really see that with viruses. We don't really see that with vaccines. So the logic, you can kind of follow it. It's just not real world, and it's just not what we're seeing.
All right, let's switch gears to vaccinating youth. I think that you've got Pfizer, which has been approved down to 12 years old. Mrna may be down to 16. I could be wrong on that. And so I'm assuming that they are working on younger than that. So let's talk about that. I've got kids in my house. A lot of folks have children, and they're making decisions for other people about getting the vaccine. So what are the side effects? Are there side effects that affect children or youth differently than adult population when it comes to vaccines?
No, not really. I mean, there are the myocarditis issue was seen more in that younger population, mostly men 16 and older, but you do see it a little bit more in youth. But for the most part, the safety data was excellent. So and that's not surprising because when you teenager and up, really the physiology is very adult-like. So we expect to see about the same thing as we normally would. I think the biggest issue, and Frank can kind of speak to this more because he does a little bit in the at Women's Hospital where there are pediatric cases. But the biggest issue is not being a pediatrician is as I look across and we listen to our pediatric and intensive infectious disease doctors and other pediatricians is one life lost may seem like a small number. I think at Children's Hospital last week they mentioned there was 20 patients there hospitalized, and that may seem like a small number. But remember, these are kids. These are our most prized possessions. These are healthy kids. They should not be dying of viruses. Everyone is an incredible tragedy. So this is not what any of these pediatricians are used to seeing. So it is absolutely shocking to them. Not only that, but their resources are not set up to take care of patients, even that volume. I know that doesn't seem like a lot, but that's an incredibly high volume, particularly when they're seeing all sorts of other viruses right now that they normally see that are dangerous in kids, like RSV, which has been a major issue. So in a similar way to the strain that Frank was talking about in our adult hospitals, they're seeing a similar strain at that level because they were already at capacity, not to mention we're about to start school. And then we start school and here we go with probably more COVID spread and other things. And so we have a similar community need in the pediatric world. So not approved below 12 yet. I'd highly encourage you to consider 12 and up. Very well tolerated. And then we'll see what the data says coming out here pretty soon on younger than that.
I'll put you on the spot. Did you vaccinate your children?
I did. 3. I got a lot of kids.
Yeah.
He's got 5. He's got 5. You're a good man with 5.
You're one to talk.
Right. The safety profile is clear and evident. My child will turn 12 in January, and we have full plans of lining him up on the day of his birthday. This is
a great birthday present. Dad.
Yeah. That's what we told him. And if we want a story about that, just to understand Just to give you a little bit of insight here on the level of trauma that goes on in my home from this, I jokingly told my son, hey, you know, I'm getting you the COVID shot. You're getting a shot for your birthday, boy. And to my surprise, because it was meant to be a kind of a jab, right, as a dad to my surprise, he blurted out, thank God. My son has watched me fight this thing for a year and a half. And some days I've come home and it ain't pretty. And he said, you know, I had COVID. It wasn't bad enough for me to go to the hospital, but I got to tell you, I looked really, really sick at home, and it scared everyone. And we just don't fully recognize what they're going through with this as well. And so I would just kind of encourage y'all to think about and consider those as well. But yeah, this is very safe, and I plan to get my children vaccinated.
Yeah, I mean, one of the questions, you can help me with some perspective here. So we talked about the risk for adults, the risk of getting COVID far outweighs the risk of the vaccine. You said that earlier. For children, the risk is much less when they get COVID. Less going to the hospital, less going to ICU, yada, yada. So, I mean, with the relative risk being so low for COVID, what would motivate me to have my children get the shot?
Yeah, I think there are a couple of things. And maybe you can come up with one that I haven't thought of, but this is just why I'm vaccinating my children. So this now just boils down to my personal opinion. So this is not based on anything. Well, I guess it's based on a little bit of science, but it's why I'm vaccinating my children, okay? So here in town, as of a couple of days ago, I haven't gotten an update recently, but we have 8 children admitted for COVID. 6 are in the ICU, 2 are fighting for their lives on ventilators. Okay? Yes, by the numbers, the risk is really, really, really low. All right? Really low. But I'm nervous as a parent looking at my child. For the parents that are in the hospital right now, or their children are in the hospital, that they can own, that number doesn't matter, right? That less than 1%, they could care less right now, right? So for me, I just want, just me looking at, yeah, okay, the risk of COVID is really low, but the risk of taking the vaccine is like nothing. So yeah, I'm just gonna go ahead and do it. I mean, it's simple, it's just math in my head. But there's another reason to do it. I have members of my own family that just aren't gonna do it. And so I feel like that we should try to do our best to protect them. And this is another way that I can do that. I can vaccinate my children so that whenever they're around, that there's no chance of transmission from them to my family. They also play with other neighborhood kids. And to protect my neighbors, I'm getting them vaccinated. To protect my friends, getting them vaccinated. To protect my enemies, I'm getting them vaccinated. And so that's why I'm doing it.
So kind of just some general questions. The efficiency of the vaccines with COVID alpha, we'll call it, pre-Delta COVID, what's the difference between that? Because that's like 90% and above, right? So does that change with the Delta variant? Does the efficiency of the vaccine change with the Delta variant?
Yeah. Okay. So yeah, and this is real time. So this is active occurring data collection as we watch Delta rip through our community, our state, and our nation. So yes, we are seeing breakthrough infections, and it's concerning. What we're seeing is roughly, we can look at this in a lot of different ways. It is observational data. So our Louisiana Department of Health is telling us that about 90%, as of last week at least, 90% of all new infections were amongst unvaccinated. It's not surprising. We would expect most to be unvaccinated. We are seeing low rates. If you are vaccinated, our most recent data suggests that your risk of breakthrough infection is under 0.1%. So it doesn't mean you won't develop it. But right now what we're seeing is less than 0.1% of patients who have been vaccinated have had a breakthrough infection. We just had not seen that. Your risk of death from COVID is 0.004, I believe, is whatever we can do the math, see what that comes out to. And your risk of hospitalization is 0.008. Okay, so we can compare that. So what we were seeing in patients who were unvaccinated with COVID, it's a wide number because it's being updated all the time, but we've seen anywhere from as low as 5 up to 15% hospitalization for unvaccinated, and we've seen mortality rates typically come up close to 2%. I think right now it's sitting at about 1.7%. You can see the risk reduction. It's almost zero. It's getting as close to zero as you can get in terms of hospitalization and death, which is really ultimately what vaccines are supposed to do. This is what we see with all vaccines. We see breakthrough infections. You get enough virus coming through a community, even if it doesn't reduce your risk. Let me rephrase that. Even if if you have a breakthrough infection despite being vaccinated, there's almost universally in vaccinations a lower risk of severe illness. Same is true here, and that's what we're seeing. Now, you get enough COVID, don't be surprised. You're going to see more breakthrough infections. You're going to hear about it. In my clinic, I believe we have 2 at Lourdes who are vaccinated and hospitalized. They are some of the healthier COVID patients. They're certainly not in the ICU.
So fresh pause. So there are 2 at Lourdes that have breakthrough COVID cases and are in the hospital out of how many?
92.
Out of 92 COVID patients at Lourdes, 2 of those were breakthrough.
Yes.
How many in your ICU?
None.
0. So everybody in the ICU were unvaccinated.
Correct.
Okay. I'm sorry.
Yeah.
I jumped in there. Excuse me.
No, that's okay. And I think I'm on Side of Live Journal as well, and I think their numbers were similar. I haven't had permission to release their numbers, but their numbers were very similar to that ratio. I think they were a little bit higher. So we're seeing the vaccine do what it's supposed to do, in short.
Excellent. Now, I know that, I think you may have mentioned to me, I hope I'm not jumping out there out of place. Early on in the pandemic, a lot of our people who were in nursing homes were getting sick. Are you seeing a lot of nursing home people come to Lourdes? You may have had some, I don't know, but are you seeing that?
None.
None? You're not seeing any?
Well, here's the deal.
Any suggestion? I mean, you're in that care.
Here's
so
the
what's
deal.
up with
So I have a little bit of so I do hospital work too. So I'm in inpatient hospital. I'm doing the outpatient. This concerned me. Delta got a little concerning to me because we're seeing these breakthrough infections. I have a ton of geriatric patients, large. I have a huge practice. And I started seeing them. Started seeing breakthrough infections. So we had patients calling me up. Hey, I got these symptoms. We're testing them. Oh my gosh, this is not the patient that needs to get COVID. So they're okay. So we're setting up telehealth visits, and we're saying, well, I want to see you every 2 days. I want to look at your face. I want to make sure you're okay. I've cared for these patients, most of these patients for years, so they're near and dear to me. And after about the 3rd visit with a couple of them, they're telling me, can we stop doing these? I mean, I like seeing you, but I feel fine. That's mostly what we're seeing with vaccinated people, even amongst the elderly. Now, our elderly people, man, they got on the ball with the vaccine. I mean, they were probably scared and they had risk factors, but our patients who are elderly, most of them are vaccinated. We have that 70-80% range going there. It's below that we really have our problem with unvaccinated people. Now that's what we're starting to see in the hospitals, and Frank can talk more to that, but that's what we're seeing.
Yeah. So in my ICU, I have one patient that has Medicare. Okay? So that gives you, I can't break or violate HIPAA, right? Privacy laws to tell you exactly what my age groups are, but I can tell you that they're much, much younger. We're talking 20s, 30s, 40s. Anywhere from 20s to 60s is about the highest it goes. And like I said, everybody in the ICU is unvaccinated at this time.
All right, we're going to hit pause up here just for a minute. I know it's late. I know we've been here a while. These guys are doing awesome. The mics are open. If you want to ask a question, I'm going to let you come on down. So we've got one to number 1. Is anybody else wanting to come to a mic? Now remember, we can only hear you at the mic. The mics are turned off until I give that mic the floor. And so we'll need to hear from the mic, not from the pew. Y'all, we're good on that? So, mic number 1, you've got the floor.
Okay, my name's Cranston Smith. I'm from Youngsville. I'd like to talk about vitamin D. I have 4 studies, very positive on vitamin D. Cliff note, summary of them, take less than a minute for each one. Number 1, this was done in Germany. A Dr. Rasmussen took blood samples of patients with COVID-19 and analyzed their vitamin D levels in relation to their coping with the virus. What he discovered is astounding. Patients with D levels below 19 nanograms per milliliter had 100% death rate. 100% death rate. Those with D levels above 34 nanograms per milliliter had 0 death rates. Above 34 nanograms, 0 death rate. Then, what is the prevalence of vitamin D deficiency in the United States? For the past 10 years, Grassroots Health has been analyzing vitamin D levels, and they've broken it down by ethnicity. For whites, about 12% have D levels below 20 nanograms per milliliter. Blacks have 55% below 20 nanograms per milliliter. So this would sort of indicate the underlying conditions for blacks having a higher mortality rate may be their vitamin D levels. For those above 40 nanograms, they don't break it down for the 34, but for 40 nanograms per milliliter, only about 20% of whites and 6% of blacks have levels above the 40 nanograms per milliliter, which from the German study would say that they would not die. So the vast majority of Americans are deficient, grossly deficient in vitamin D. Then there was double-blind studies. There was one done in Spain. Of those admitted to the hospital, they divided them in half. One got standard treatment plus a placebo. The other half got standard treatment, the same treatment, plus vitamin D. Huge doses of vitamin D, vitamin D2, in the hundreds of thousands of international units. Of the placebo group, 50% ended up in ICU, 5% died. Of the vitamin D group, I think it was about 2% ended up in ICU, 0 died. Okay, so the vitamin D levels that we should take. I'm taking 5,000 units a day, which is a safe dose unless you have a family history or a personal history of kidney stones. So you have to take some extra precautions there. But basically, for children, you don't want to give 5,000. Give 1,000 units per 50 pounds of body weight is a very safe dose. And another study that was done, for every nanogram increase in vitamin D levels, blood vitamin D levels, it reduced the incidence of getting COVID by 1.6%. So with me taking 5,000 units, my chance of getting COVID is 80% less. It's not 100%, it's not, but it's pretty good. And for those that do get it, according to these other studies, the risk of death is almost zero.
All right, so what would you, are you asking if we're using that? Are you asking what the
Comments
perspective on it? Okay,
on vitamin- I'm
let's
also-
give these guys a chance to
I'm
answer.
also taking zinc 30 milligrams.
Let's give these guys a chance to,
Yeah,
on
we
the vitamin
may,
D.
we may both have some thoughts on that one. Vitamin D is interesting. Vitamin D is something that, gosh, probably the early to mid 2000s was really a hot topic because there was a lot of observational data that, seemed to indicate that vitamin D deficiency was associated with a whole heck of a lot of disease. I mean, it was heart disease and heart attacks, and it was a lot. I mean, there was like 10, 15 different things. And it spurred a whole heck of a lot of studies, prospective randomized control trials, just to see. And what we learned was there wasn't so much a cause and effect as it was, hey, vitamin D deficiency may not be a good thing, but supplementing vitamin D as a treatment for a disease didn't seem to impact the outcome, whether it be heart disease or any other. That's basically what we're seeing with vitamin D now. We don't particularly want people to be vitamin D deficient and have COVID, but does it increase mortality or not? It may, but we don't really know that treatment lowers it. That's what we're seeing in most of the studies that we look at, but I don't know if you...
Yeah, I was going to echo. I remember in residency having to check vitamin D levels on every ICU patient and treating that, thinking that was part of the paradigm of getting them out of their critical illness. And later, those subsequent trials have just not borne that out. There were a lot of observational data, but when we actually did randomized controlled trials, that didn't bear out. Specifically for COVID, I'm going to be honest with you, I'm not familiar with vitamin D with specific COVID, but I do know the other ones in terms of zinc and vitamin C, and those have, without question, have been not associated with improved outcomes.
The other thing I'd mention is, amongst my patients, I have, just to kind of, let you know, I have had several patients with vitamin D levels well above the ones you're talking about who have been hospitalized and died of COVID. So I can tell you the number's not zero. I don't know what that number is without more data, but I have had plenty of patients on vitamin D, high doses, zinc, all of it.
Number two.
Sure. So my question just has to do with more of the vaccine and how it mutates, right? And so, not the vaccine, the virus, sorry. And so, given the vaccine now and that kind of stuff, we're kind of seeing this Delta variant as kind of a mutation of the virus trying to survive as we're vaccinating more people. They're concerned that we create a virus that is stronger and scarier by supplementing these vaccines to people without knowing exactly what the virus is going to respond to it.
So I think that from the medical community, there's an opposite concern, that if we don't vaccinate, we're eventually going to hit a mutation or a variant, then the vaccine will no longer be effective and we'll be back to square zero. So in theory, if we were to vaccinate 100% and eliminated the possibility of, and let's assume for the moment that the vaccinations were 100% effective, which no vaccine is, but let's just make assumption for just kind of understand the context of variants. We would not have variants. If we could 100% vaccinate, 100% effective, we would wipe out the virus and there would be no variants, at least in the US. And assuming if you could do that worldwide, then you wouldn't have that any further, because as each time, viral replication inside the body is a messy process. It's sloppy, okay, for lack of a better word. It doesn't replicate with great accuracy. And it does that sort of kind of on purpose so that it can mutate and get better each time. And so with each infection is a possibility of a new mutation, which is then a new possibility of less efficacy from our vaccine, possibly. Haven't hit one yet. The Delta variant is the scariest one because it did reduce the efficacy of our vaccine to prevent infection entirely, but it's salvaged in the fact that that the chance of death or hospitalization with vaccinated patients are still exceedingly low. So given that, we're still in that safe territory, but as we move forward and continue on with the ability to continue to mutate, it's not just here locally or nationally, but internationally, like globally, as we continue to allow this virus to run rampant, that's when eventually you're going to see more mutations arise.
Thanks. Microphone number 3.
Hi, my name is Tom Sammons, and I think the media does a pretty good job portraying that there is a mortality rate of about 2%, 1.7, I think you said. But my question is, like, I'm a dentist, and in my practice, I've seen a lot of patients that have had COVID, been in treatment, and have survived, but they have had short-term memory loss, loss of motor function. And I don't think that's being portrayed very much in the media. And I just wanted to see what y'all are seeing from this long-term care of being in the hospital. And yes, you might have COVID and might survive, but what are some of the long-term effects of being in treatment for so long?
Yeah, that's a good question. So, yeah, we're not really sure, but there is clearly a this is so just in viruses in general. We talk about the side effects of vaccines, but pretty much every side effect that you can possibly imagine seeing with a vaccine, you will see with the virus, and typically you will see it more severely and more often. But the same goes for long-term side effects. So COVID's new, and so long-term is something we've just been seeing over the last several months. What are people experiencing, and does it go away or does it stay? And of my patients that have had COVID, we're seeing anywhere from about 10 to, it's a wide number, 10 to 30% are complaining of things like memory loss, short-term memory loss, and they're describing it as a fog, and some people say it's a COVID fog or COVID fatigue. The residual fatigue is really common. It's fairly minor, and yet it's frustrating. Probably the most severe complication that we have had some delayed clotting issues. So that's been an issue. I've had 2 patients who had blood clots. I'm trying to think, probably about 6 to 8 weeks after. So that's pretty far out for side effects. Such that they were hospitalized, again, not for COVID, but for the blood clots. But yeah, that's a real concern, and whether or not it goes away, we don't know. We had one of the physicians in my practice had COVID early, not as early as Frank did, but maybe shortly after, and had the same symptoms and felt like it affected her practice for quite a while, as well as her ability to exercise and do normal activity. She felt like it improved and pretty much normalized after about 6 to 8 months, but it took about 6 to 8 months before she felt like she was back.
Very, very good. Thank you. All right, number 1. This looks like our last question unless somebody else jumps up, but number 1.
Okay.
Into the microphone. Do you need to angle it down a little bit? Feel free to do so. Sorry about that.
Aren't we funny today? Okay, so here's the situation. Guillain-Barré syndrome survivor, in the hospital for 18 months, was paralyzed from the mouth down, literally. Only way to communicate was with the eyes. Has always been told, no flu shots, no pneumonia shots, no MMR boosters, nothing like that. Yeah. Where do we stand? We've looked, and there seems to be so much conflicting information.
We may both want to weigh in on this because it not only just is, but your specific situation is tough to give a hard recommendation either way, okay? But what I'll say is this. There is some potential association with Guillain-Barré with the J&J. That has not been definitively associated yet. It is actively being investigated. So we don't know yet, but there's this signal of a possibility. So far, with Pfizer and Mrna, there have been no cases of Guillain-Barré, despite, and this is worldwide, 4 billion injections, okay? It doesn't seem to be there. Of all the hesitancy that's associated around these vaccines, you're the one that I go, oh yeah, I get it, right? Boy, it's hard to advise you, even with the safety profile that I know, to go ahead and get it, because the consequences are so severe. If I go purely based on the science, then I would say that Pfizer and Mrna are probably safe for you. Because so far we haven't seen any Guillain-Barré, okay? Interestingly, like he talked about briefly, that most of the serious side effects that we have from the COVID vaccine, we also see with COVID itself, okay? We don't see Guillain-Barré with COVID either. It's one of the things it just doesn't seem to do.